Hello everyone, my name is Dr. Deepti, and today we'll be taking up discussions of some clinical cases to give us an orientation of the clinical presentations, the investigations, and what could be done for them. And the first case that we're going to take up is going to be adenomyosis. Adenomyosis is a fairly common disorder in women in their 40s and 50s, but quite often misdiagnosed. And let us see this particular woman who presented to my OPD. She was a 45-year-old lady, para 2L2, who presented with complaints of painful and heavy menstrual bleeding for past 1 year. And on examination, on the pelvic examination, the uterus seemed to be diffusely enlarged. It was about 8 to 10 weeks pregnant uterus size. It was tender to touch. Although the bilateral adenexa were normal, non-tender, the pouch of Douglas was free, again non-tender. And keeping in view these chief complaints, which are painful, heavy, but the key word here was menstrual bleeding. So it was not an irregular bleeding that she had. And a uterus which is enlarged and also tender made me to think first in terms of adenomyosis, keeping a fibroid uterus and endometriosis lower down in the differentials. Keeping in mind my provisional diagnosis, this patient was advised an ultrasonography, and let's see what the pelvic ultrasonography showed us. Now, the ultrasound picture was again of a diffusely enlarged uterus. Again, it does appear somewhat about 8 to 10 weeks pregnant uterus size. And if you look more closely, the enlargement is more on the posterior wall of the uterus as compared to the anterior wall. Classically, if we talk about the myometrial appearance, it is a very heterogeneous appearance. There are hypoechoic areas in the myometrium mixed with the hyperechoic areas, and this classic heterogeneous appearance of the myometrium in ultrasonography is often called as a salt pepper appearance. Again, something that we can see here, this the white line in the center, the hyperechoic line, is the endometrial stripe. And as you can see, just beneath the endometrium here, right here, there is a subendometrial cystic lesion. Again, something very characteristic to adenomyosis on ultrasonography. If we look at the distinction from the endometrium to the myometrium, which is called as the endomyometrial junctional zone, is not very well defined, and it does appear somewhat thickened. And one of the other classic appearances that we might see on ultrasound, although is not very clear in this particular picture, are called as subendometrial echogenic striations. So we see these striations going from the endometrium to the myometrium, again classically called as the Venetian blind appearance on ultrasonography. And these findings were again highly suggestive of adenomyosis, and this patient was then asked to get an MRI done. And this is the T2 weighted MRI sagittal section of the same patient, and this is the pubic symphysis, the urinary bladder, and again a classically enlarged or a diffusely enlarged uterus in this patient. And if we look again closely, the posterior wall somehow appears more thicker or more enlarged as compared to the anterior wall, something which is seen with adenomyosis. And though again the hyper intense central echo is the hyper intense central line is the endometrium. And if you again see the endomyometrial junctional zone, now this junctional zone is a zone of compact smooth muscles which is seen just beneath the endometrium. And again, this junctional zone all here around seems to be really thick. Now this entire thing is the junctional zone well, and this small area here is the normal myometrium. And if you look at the junctional zone, it is thickened and it looks definitely more than 12 mm thick, and that's what we say, that if the the junctional zone thickness is more than 12 mm, it is highly likely to be adenomyosis, whereas if the junctional zone thickness is less than 8 mm, it is unlikely to be adenomyosis. Again, what we see here are areas, hyperintense areas in this junctional zone of the myometrium, which have a similar intensity as that of the endometrium. These could be the endometrial glands with the blood in it, because the endometrium it consists of both glands and stroma, which has gone deep into the myometrium, is responsive to the hormones, and it bleeds, and maybe that's the reason it's appearing hyperintense here. And looking at the classical picture of both the ultrasound and the MRI together, she was diagnosed as a case of adenomyosis. As far as the treatment is concerned for these patients, the only guaranteed treatment for patients who have adenomyosis and who have completed their families is a hysterectomy, right? But for patients who have not yet completed their families or who don't want to undergo a hysterectomy, the other options could be progestins or even progestins in the form of an intrauterine device, that is a Mirena or GnR agonist, and even aromatase inhibitors have been seen to reduce symptoms of menorrhagia and dysmenorrhea. Classically, the OC pills or the oral contraceptive pills have not been found to be very useful for the treatment of symptoms in patients with adenomyosis. A new modality that is being used for adenomyosis is uterine artery embolization, although the number of cases that have been done are really small to give it as a guideline or as a guideline. And the only way to confirm, or the gold standard, as we say, for adenomyosis is a post-hysterectomy, a histopath specimen, right? And this is a characteristic histopathology specimen of the adenomyosis. What you see is endometrial glands. So these are the endometrial glands which are present inside the myometrium. Now, the key thing here is that when you see these endometrial glands, to label the patient as a case of adenomyosis, these glands should be at least one high power field deep to the junctional zone, or we say 2.5 mm deep to the junctional zone for confirmation of the diagnosis. And as we can also see, the myometrium, or the smooth muscle cells around these glands, often show hyperplasia as well as hypertrophy. This was the complete picture of a patient with adenomyosis and how she presents and what could be used as the diagnostic modalities. And the take-home message is that the initial investigation to go ahead is ultrasonography of the uterus or a pelvic ultrasound, and definitely the investigation of choice for confirmation of diagnosis is an MRI scan, while the gold standard is a post-hysterectomy histopathology specimen. Right, thank you.